Hello, everyone, and welcome to Ulnar Nerve Transposition. Once again, this is a multi-specialty procedure. It goes with hand and plastics. It can go in neurosurgery and it can go in orthopedics. So lots of places for us to be able to look at this surgery. All right, what's the definition? It's a repositioning of the ulnar nerve, and we're freeing it from its original location, which is Guillen's canal, and we're bringing it anteriorly. So we're taking it off of the medial epicondyle, and we're bringing it up above the epicondyle to give it some more room. So what's our surgical anatomy? Well, of course, we have the ulnar nerve. We have the medial epicondyle of the humerus. We have the flexor carpi ulnaris muscle, which goes over the top of the area where this is at. The medial intermuscular septum, this is what divides the muscles right there and where the nerve runs. And we have the brachialis flexor muscle, which is the muscle on the other side of this septum. What physiology do we have? Well, it's a motor and sensory nerve. From your ST for ST book, it says the nerve runs through the cubital tunnel in the hand, and in the hand it is called Guillen's canal. So the cubital tunnel is up on the medial epicondyle, Guillen's canal is down in the hand. However, when we talk about sensory, we're talking about the the medial part of the hand when we're standing in anatomic position. So we're talking about the pinky finger, ring finger, and long finger. It will cause numbness and tingling when this nerve is compressed. It can cause motor function loss if this nerve is compressed. This nerve used to be damaged quite a bit, and that was how you ended up with cubital tunnel, is if you were an athlete and you injured your nerve. Now this nerve gets injured a lot because we flex our arms quite a bit, watching our phones and our screens. So this nerve actually has become more inflamed over time due to our lifestyle changes. So if we look at our muscles here and our tendon, here's our nerve as it runs through. This is our medial epicondyle right here. This nerve, there's a groove right here in the medial epicondyle. This nerve runs right inside of there. So as the elbow flexes, the nerve is stretched over the top of the medial epicondyle. So what we want to do is release that by excising this cubital tunnel. We actually just open it up and allow the nerve to be free, and then we move the nerve up on top of the epicondyle so that it doesn't get stretched when we are bending our elbow. All right, so what is the indication? Cubital tunnel syndrome, and it is often due to trauma, like I said in the past, but now it's more due to our screen time. Diagnostic tests, mostly just an H&P. We can do electromyography like we do for carpal tunnel syndrome, but most of the time it's pretty obvious when you do a diagnostic test that you have cubital tunnel syndrome. Some special considerations, it can be done by a neurosurgeon, an orthosurgeon, or a plastics and reconstructive surgeon. We may need a sterile tourniquet cuff, depending on what surgeon's preference is. Special equipment, we're going to need a tourniquet. We're going to need a hand board as well. Our instrument sets and specials, we're going to need a minor set, a small bone set possibly. A hand set is also something that's appropriate. Special supplies, we'll need vessel loops or a small Penrose drain, a possible sterile tourniquet cuff. And then our medications, local anesthetic for post-op pain, and depomedrol or other steroid if our nerve is inflamed. Anesthesia, this can be done on a general, regional, local MAC, or a local. Positioning and equipment, we're going to be supine with a hand table and the arm extended out onto the hand table. We also need sitting stools for this procedure. Prep, we're going to do betadine prep and scrub or Dura prep because we're working with a nerve. We don't want chloroprep. We're going to prep the area of fingers up to the tourniquet. So this is, once again, quite a wide prep. We're going to go fingers and probably up to 3 or 4 inches above the elbow if the patient has that much room to put the tourniquet. However, we don't want to get betadine underneath where the tourniquet's going to be. And we're going to prep circumferentially so the entire arm is prepped. All right, draping. We're going to put a down sheet and then 2 U sheets to square off the area, and then our extremity sheet. Our incision is on the medial aspect of the elbow, right over the epicondyle. Procedure steps, once again, super easy as far as to write down. We do our IHDR. We're going to dissect the ulnar nerve from the cubital tunnel. We move the nerve to a new position anteriorly, and we secure it. Usually with a little suture. We take a little bit of tissue and bring it over the top of the nerve and secure it, and then we're going to inside or irrigate, hemostase, close count, dress, and put a splint on. And this is what it looks like when we are done with the procedure. So our ulnar nerve is here, and it used to run down here over the top of this epicondyle, and we have moved it up on top of the epicondyle, maybe taken a little bit of muscle here, wrapped it around, and sutured it so that it would stay in place up there. This is what it looks like when it's all dissected out before we move it up. So here's our medial epicondyle, here's our nerve. We have a vessel loop wrapping around the nerve so we know exactly where our nerve is. All right, after our procedure, our counts, we're not going to count instruments, so we just count our sponges and sharps for initial and final closing. Dressing, we're going to use a daptic or Zeroform, 4x4s, fluffs, then maybe a cling, put a splint on, and maybe an ace bandage. We just want to really protect this nerve and make sure that it's immobilized for the patient so that it can heal. We don't usually have a specimen, so we don't need to worry about that. The destination is PACU and outpatient. The patient's going to go home the same day. Their prognosis is excellent. Complications are bleeding and infection, and of course damage to the ulnar nerve, which could be devastating for our patients. Our wound class is clean. And then once again, we have excellent websites to go check out. I hope you all have a great week. Bye.